What I'll be talking is combined vitrectomy with posterior valve. Fortune favors the bold. I don't know whether I'm bold or it's a demand of time where we have to take unexpected steps to save the patient or to preserve the vision of one-eyed patients who are going blind. And that's why we came up with this procedure called posterior valve. Neovascular glaucoma, uveitic glaucoma, iridocorneal endothelial syndrome, epithelial ingrowth, post-penetrating keratoplasty uh, are some of the refractory glaucomas which are unresponsive to medical therapy or challenging to manage with conventional surgical modalities like trabeculectomy. Glaucoma drainage devices have been used extensively for management of such cases of refractive glaucoma, especially if you see a patient of penetrating keratoplasty. We have done a glued IOL with a posterior valve. This patient had an intractable glaucoma. This patient has already underwent a trabeculectomy procedure. You can see a PI with pseudophakia, and this trabeculectomy has failed. So now we have planned this patient for posterior AGB with vitrectomy. The first question comes in mind: why posterior approach in neovascular glaucoma? Because of the recurrent inflammation, the corneal endothelium is compromised, the angle is vascularized. So if you place a tube or if you do a trabeculectomy, you are liable to damage the angle or the neovascularization in the angle, which can lead to bleeds, postoperative bleeds or intraoperative bleeds. In many cases, the angle is obliterated because of pus, and in these kind of situations, it's extremely difficult to place the tube in the anterior chamber or do a pus trabeculectomy. Small eyes with inadequate anterior chamber depth, the placement of tube is extremely difficult. So what we do a pars plana tube placement in these kind of patients after doing a total vitrectomy. Uh, NVG in posterior valve is preferred whenever you have a shallow anterior chamber. Vascularized angle can lead to intraoperative and postoperative bleeds. Inflamed eye and anterior valve can add on to the inflammation. So we do prefer a posterior valve in all these kind of patients. But this procedure also has a limitation. You cannot do this procedure in the phakic eye. The patient should be a pseudophakic. You need a complete retina setup, and a VR surgeon is required to do this procedure. So a glaucoma and a VR surgeon is required for a good surgical outcome. So you have to join with the two specialities to give a better outcome to the patient. Now we see a case of proliferative diabetic retinopathy with NVG, one-eyed patient, other eye it's pale negative because of NVG, uncontrolled IOP on maximal medication. 3 months back, cataract and trab was done in first sitting, but after 2 months of doing trabeculectomy with cataract, the trab failed. The pressure again went up to 50 on maximal medication. We had a fundus visualization, so we started doing a pan-retinal photocoagulation. We ablated the retina right from the ora to the posterior pole. And then we planned for pars plana vitrectomy with posterior valve. You can see this is a pseudophakic patient, and we put a traction suture. The valve is checked for patency with 30 gauge needle. 8 millimeters behind the limbus, we place the valve, and after putting silk suture, we make a 5 into 5 millimeters flap. Once the flaps are made, then trocars are placed. It's important to do an anterior vitrectomy because the valve tube will come just behind the lens. So all the vitreous should be removed from this area. Then we, under visualization, we go to the posterior pole. You can see a lot of laser marks. It has been well lasered. This white spots, what you can see is a laser marks. It's important to do a near total vitrectomy. So PVD induction is done with the help of tricot. You can see we are inducing the posterior vitreous, and the posterior vitreous is removed. Once the posterior vitreous is removed, the vitreous is also removed till the equator or beyond equator. We don't go for a very aggressive base dissection. 2 millimeters behind the limbus, we create an fistula. From this fistula, we introduce the tube inside the eye, and you can see the tube coming behind the IOL. Once the tube is placed, what we do, we suture the flap, and in all our cases, we are putting a sterile patch graft to the exposed part of tube, because initial cases we had incidents of tube exposure, and then the conjunctiva is closed. You can see a well-centered tube, and this patient actually had 636 vision. After surgery, improved to 612 vision, and the pressures are maintained nicely. It's coming 612. Like any surgery, this surgery also has a complication. In early phase, you can have hyphema because of NVI. So it's always better what Ritesh suggested. Before going in for surgery, you can put an anti-VEGF. So chances of hyphema will decrease. You can have hypotony like in any other filtering surgery or glaucoma. Vitreous incarceration of the tube can occur, and you can have an increased intraocular pressure. So you should make sure that the vitrectomy should be total. If this problem comes, then you can go inside and do a repeat vitrectomy. Vitreous hemorrhage, retinal detachment can occur in these eyes. And because of hypotony or sudden decrease in pressure, you can land up into a situation called choroidal detachment, which usually subsides over a period of 2 to 3 months. In late complication, you can have an tube exposure. Looking at this complication, we had 2 patients of endophthalmitis. Looking at this complication, what we started doing is we started putting a sterile patch graft on the exposed part of the tube. So our incidence or exposure of tube reduced, and now we don't have any after having sterile patch graft, we don't have any endophthalmitis patient. One patient landed up with an iris cyst. This is an article which we have published, that is pars plana AGV implantation in refractory glaucoma, surgical technique and long-term outcomes. In this series of 28 patients, the main cause of refractory glaucoma where we did this procedure was neovascular glaucoma. That was somewhere around 20% of the patient. The results, if we look at the results, the mean IOP was 38 millimeters. And after surgery, doing a pars plana vitrectomy with posterior AGV, the pressure reduced to 12.76. And with this, patients are maintaining, we had a maximum follow-up of 3 years, and patients are managing good intraocular pressure with good increase in visual acuity. If you look at the IOP, there was a statistical significance of reduced IOP. The patients had a primary outcome and a secondary outcome. 60% of the patient maintained a primary outcome where they didn't needed any anti-glaucoma patient. Rest of the patient needed 1 or 2 anti-glaucoma drugs. Other finding what we see in this study was the visual acuity. Visual acuity improved in somewhere around 52% of the patient. 30% of the 48% of the patient had the same vision, and 2 patients had decreased vision after surgery. So to conclude, AGV implantation through pars plana can be a secure and successful option in patients with NVG. It effectively lowers the IOP and reduces the number of glaucoma medication, and is especially successful in patients where filtering surgery has failed. Thank you very much.